So we shall now go on to next speaker, Dr. Mayank Agarwal, who's a leading senior consultant practicing at Jindal Eye Hospital, Jaipur. And he has another very interesting presentation to show us. Dr. Mayank, are you connected? Hello?
Can you hear me, ma'am?
Yes, yes, we can hear you. You could share your video.
Yeah. So I'll be presenting a case, which is normally to all of us, it's a challenge. So it's a intumescent hard brown cataract. So I started with the neck and aspirated the fluid, then flattened the intake capsule by re-egg the viscoelastic. And now the NTA capsule is flattened enough so that I could make a good rhexis of around 4.5 to 5 millimeters in one go. Now you can see that it's a very hard leathery cataract. I usually make a 2.2 millimeter single planar incision and just go straight. I don't do a hydro dissection because the fluid has come out. I'll just check by rotating the lens that it is freely rotating or not. It is freely rotating. And then my preferred technique to do is a stop and chop. So I make a deep trenching so that the most of the core of the nucleus is being taken out initially, and then do a chop. The terminator chop, as advised by Dr. Rajendra Prasad, I am not doing that. I am just giving multiple chops to the nucleus so that this central core comes out. You will see that soon. I am giving multiple nicks at the periphery. And without putting much pressure sideways. And the core now is getting separated. Few more nicks and it will come out. You see that now this core I can lift up. Now this core is being lifted up, been divided into small pieces and eaten up. Now there is a lot of space inside the capsule bag. So my maneuver will be, I can make more lateral movements if I have got space. Still it is very leathery, not dividing to the fullest. So I try to take 1 or 2 pies, leaving the central attachment still on, which will be taken out later. So it's not, see, it is not being divided, still not divided, still attached at the center. Now for few cases, I do a horizontal chop like this, where I move my chopper from nasal to temporal side and separate it from the center so that I can take the piece out. Now everything is being divided and I can take a good sigh of relief. The settings, normally I keep my phaco at 50% phaco power and vacuum of around 400 in these cases. It is important to make even smaller pieces. It's a little fast forwarded and high speed video, so you cannot appreciate all the things. And a 3-piece hydrophobic lens is being implanted into this eye. Thank you.
Thank you very much, Dr. Mayank Agarwal. That was a very difficult, challenging case, and each of us have to get innovative into how to deal with it. And there was some amount of intumescence. I'm going to ask Dr. Kapil first to comment on what are the tips which we need to have in mind when you're doing a hard cataract and also there is an intumescence there?
Thank you, Chitra. The first thing that I would keep in my mind is to make an adequate sized section, because however low power we use, we have to use it for a longer period of time in hard cataracts, and there are chances of wood burn even with the finest of machines. Number two, I would like to keep my rexus at around 5.5 millimeters rather than 5 millimeters. It has to be slightly bigger so that you can, handle these kind of nucleus easily. The size is bigger, almost there is no cortex existing in such cases. But the advantage with these kind of things is that once you have entered the nucleus, it cracks very easily. So my every surgeon has his own style, and I am comfortable with going very deep into the nucleus. I don't go up to the periphery, and I try and crack it. And most of the times I find that the crack extends to the other end also. So I still divide it into 4 pieces or 6 pieces and take out tip by tip. But then again, the doctor has demonstrated a very good technique to separate out the hard nucleus from the center, eat it first, and then rest of the things will follow automatically. So what I do is that one thing to keep in mind is that we are chopping the nucleus and not the cortex. So we have to be very deep in these kind of cases into the nucleus, and we have to destroy the nucleus. Thank you.
Yes, wonderfully said. Dr. Ramurthy?
Yeah, I think Kapil has said most of the things, and a nice presentation, Mayank.
Yes.
All I would say is that, one thing that bothered me was that there was no distinct separation. In these hard nucleus, the most important reason is to get a through and through chop. And, we have to see the chop extends right through. And what I do normally is to, in the subinterstitial area up to the center, create a fairly deep trench, have at least 1.5 millimeters of my tip exposed, get a nice purchase and chop the nucleus. And I want to see the chop going right through, and so that I can see the red reflex behind. In case that does not happen, in some cases, very hard nucleus, sometimes even in very soft cataracts, you can't get that. So I just go ahead and extend that right through and convert it to a stop and chop like what you're doing. Sometimes even go with 2 Sinskey through the 2 side ports and get 2 heminuclear distinct. What I want is to break the backbone of the nucleus. You had something like a flower petal, you did manage to take it out, and I'm sure the final outcome was good. But then if you're able to separate them, whether it's into 6 quadrants or into 2 heminuclei, and you can see the chop propagating right through, the whole surgery proceeds in a more controlled manner. Of course, I'm sure maybe it got edited out. In these cases, I use a dispersive viscoelastic and often refill. That's to protect the endothelium. And secondly, the Sinskey hook is slightly inside. When the nucleus fragments invariably come out, I use it to protect them from hitting on the back of the endothelium. That ends up with a slightly clearer corneas in the postoperative day.
Dr. Mohan, without repeating what the other 2 expert panel said, you have anything extra to add? That was good, Dr. Mayank. That is a courageous surgery.
Yeah, I would have done puncture rexus, because the advantage of puncture rexus is that you can get a bigger rexus, whatever you want. Okay. And another thing is, I would tend to agree with Ramurthy that you need to use a sharp chopper. Maybe my chopper, Mohan Rajan chopper 1.75. Maybe go, because you need to go. What I do is I do a vertical chop, because this nucleus and more nucleus in this case. 8 to 10 millimeter nucleus size is there. You need to go all the way down and see the posterior capsule through and through. The posterior capsule has to be seen through and through before you. And I first divide the cataract into 2 halves, chop one side and rotate 180 degree, chop the other one, so that I get the 2 halves, then attack each of these halves, make it into smaller pieces. If you try to take this without cutting the posterior nuclear plate out, the entire nucleus will start coming out like what you have seen in this case, and you will have a white cornea the next day. So that is the thing. So because these nucleus are very, very bulky, you need to make it smaller pieces, make sure that the chop goes all the way down. Now and then replenish with viscot into the anterior chamber.
Yes. Thank you, Dr. Mayank. Be with us. A lot more interesting videos along the way.
Thank you very much, ma'am.
Yeah, thank you very much.